Did you really? Because it's about 5 after and people are showing up. So.
You go red. You go green.
There we go. Okay, so I'm on now? Yeah, there I am. All right. Good afternoon, everyone. I want to welcome you all to another one of the Age Education Training Center programs. This is the third one we've had with the new Age Education Training Center. I want to thank you all for coming today. Today we actually have Dr. Ben Raimer, and this is Dr. Raimer's biography. I'm going to read every word of it very slowly. No, I'm not. Needless to say, Dr. Raimer is a very accomplished physician. He's a pediatrician. He's had numerous academic appointments at UTMB. He spent his whole career here, and he now is the vice president for Health Policy and Legislative Affairs. Now that sounds really dull and really dry, and oh my God, how boring can it be? But the bottom line is that what Dr. Raimer does is he does two things. One is he helps the legislature in the state of Texas come up with legislation that affects healthcare. And you all think that, that may be a dry subject, but we can see as healthcare reform and other things go through how what happens at those levels actually affects our daily lives and affects the daily lives of our patients. And I think that's a very, very important thing to understand that process and how it affects us. The second thing that he does is he also helps keep UTMB well funded. And for that, we thank you very much. What he's going to do to talk to us today is about how health policy affects healthcare, and with also shedding some light on the HIV aspects of that. So without any further ado, let me bring up Dr. Raimer. Your life.
Thank you, Dr. Kaiser, very much. You're very kind. It's a privilege to be here to talk with you. It's always a privilege at my age to get invited anywhere. So I want to talk to you today a little bit about the politics of healthcare. And one of the questions that comes up very, very often is with the Affordable Care Act / Obamacare, what has that done to funding for special programs in our world of medicine, special programs, particularly your topic, that is HIV education and AIDS care access. What has the Affordable Care Act done for that? And I want to be able to talk with you a little bit today about that. And in order to do that, I'd like to give a little time to just the historical concept of healthcare in general. So that we can understand and come to the contemporary place of where we are. Actually, universal health care access is not a new thing. Otto Bismarck tried that in Germany back in 1883 with a universal sickness law. And you always like this or dislike this. Health is defined always as sickness. Insurance is defined as sickness. It's only in the last 10 years that we look at keeping people healthy, that you look at caring for your HIV patients with the thought in mind of not managing a crisis, but preventing one. So we have come a long way there. In 1948, the United Kingdom, right after World War II, decided to try out its National Health Service. I had an opportunity to train a little bit in the UK and see that firsthand. And in spite of America's rejection of that concept, I saw opportunity for people to have better access and an improvement in overall life and quality of care. The United States, by the way, is the only country that still does not provide universal health care access. Did you know that? We're the only country in the world that does not address that. We've tried. 1912, Teddy Roosevelt, running about this time of year in the Bull Moose Party, championed national health care. Teddy did not get elected from the Bull Moose Party that time around. He got elected another time. Roosevelt had this as his cornerstone platform. And then the Great Depression was so devastating, he opted to put in Social Security instead of national health care. So a little switch off there, but it was on his agenda. And of all things, Harry Truman, who's looked at often as a very, very conservative individual, also created a national insurance trust program with voluntary payment. The AMA, American Medical Association, denounced it and said it was socialized medicine and defined it as poof. And poof it went. It wasn't put in place. The next person who tried to do that was Richard Nixon, a Republican, and he wanted to require employers to cover their workers and create federal subsidy to help everybody buy private insurance. Unfortunately, he got run over by Watergate, and it did not work then. But along came Bill Clinton. He put together a plan, and unfortunately, his plan for universal coverage did not get off the ground. And many people would attribute that to the fact that most of the planning for that was done behind closed doors. It was sort of a secretive process, limited to about 300 people. It would have been a universal coverage type of plan, but Congress certainly didn't embrace that. Then came President Obama, and timing was right, the mood of the country was right, and they passed universal coverage through the Patient Protection and Affordable Care Act. Sometimes people forget the patient protection part of that, but it's the PPACA. And here we are now. What does that mean for our patients that we've experienced this for a few years? Well, there are 2,700 pages of the Affordable Care Act if you want to read all those. I've not read every page, but I have at least looked through many of them. For years in healthcare, most of you who are not as old as I am, so you don't remember this, but hospitals always came up with a charge master, a way of charging people to cover the people who did not have health insurance. We call that cost shifting. So you as a UTMB employee, if you're one, would have paid more when you came into the hospital to make up for those people who didn't have health insurance. Every hospital in the country did it. That's just the way the system worked. It was an unofficial way of providing health care for the uninsured, but in many ways it was a tax on people who did have health insurance, or at least a tax on the employers who provided that health insurance. So ACA was really a very uncomplicated process that you can explain it without reading the 2,700 pages, because all it did is to insure the uninsured. It legitimized that process. We made everybody uninsured and then asked them all who bought insurance again to pay more for it in order to cover those who were uninsured to begin with. So it may sound silly, but if you give it a little thought, that 2,700 pages boils down to that simple process of a tax, and later on the Supreme Court verified that that is a tax on health care. Not very popular in either political party, but it's the way the system works, and probably the only logical way it could work in a fair sense. Well, we come to 2016, we have a lot of issues facing us in the country. Most of you know that from looking at the TV every night, and unfortunately it's not a reality TV show that's a comedy. It's a very serious one as the drama unfolds with our political parties choosing candidates to run for president. There are some things facing Congress that are simply put on hold right now until that process is over. One is the federal budget itself. There have been a lot of negotiations on that affect health care. The other is something called the 21st Century Cures Act, certainly something gravely important to those people who are doing HIV and other funded federal research. Also affects the Department of Defense and their budget for research. Congress made a huge step this year in increasing the amount of money in that research fund. But we still got to get it through some more budget process for it to be official. Some people really feel that the first order of business after this election, if there is a Republican victory, is there'll be a repeal or revision of the Affordable Care Act. Now, that's, in my opinion, going to be a difficult process because once you're on the bicycle and you're riding, it's hard to just hop off. So I think it's going to be a lot more complicated than some of your presidential candidates think. And when it comes around to telling many of you in this room that you can no longer keep your kid on your health insurance up to age 26, or that they're not going to cover your prior condition, medical condition, that's probably not going to play very well with the general public. So don't expect the ACA to go away with the stroke of a pen from the Republican winner. That Republican may not even win the way things are shaping up. There are some changes for hospitals too, disproportionate share payments, elimination of hospital-based clinic fees, and also a reduction or narrowing in the 340B drug benefits could affect all of our patients, including those with HIV. So we have a whole lot of work ahead of us. UTMB is actively engaged through an organization called America's Essential Hospitals, and we spend a lot of time in Washington working with committees and individual congressmen and senators to try to explain to them the critical need to maintain medication availability for our patients and also to maintain access to hospitals and clinics. There is also some major changes going on related to Medicare, from a fee-for-service to a quality reimbursement program that will trickle down to Medicaid also. So there's some issues in the background you need to keep your eye on. There were basically a couple of building blocks for ACA. One was to have an insurance exchange in every state, and states were given the option that they could do their own exchange, or the federal government would do it. A lot of states just put their head in a hole and said, I'm not going to fool with that because it'll really get vetoed or something will happen to derail it. That did not happen. So the state exchanges in many states were not ready to accept patients. The federal government had to step in and do that very quickly. The other thing that was highly important to the success of the Affordable Care Act was Medicaid expansion. The eligibility would change and that would occur. As you know, many states elected not to do that. We're going to talk about that in just a second. There was also supposed to be a competition among insurance companies for business that would grow out of this that actually lowered prices for insurance. Unfortunately, the track record so far has not done that. The net cost for insurance actually gone up. Now, if you think about it in just a logical sense, you would expect that. If you have more people insured, the cost is going to be greater. The utilization is going to be greater. In the past, a lack of insurance was a major barrier that prevented people from getting prevention care, immunizations, seeking treatment early in a disease process. Now that that has occurred, that access is more available, the cost of that care has actually increased. But that shouldn't be a surprise for anyone. Well, what's the future for the Affordable Care Act and for our patient populations? You know, it shouldn't be any surprise, as I've said, that the cost went up. There should be transformational models of care on our track to deal with that. In other words, the more we go out and create medical homes and single places like your clinics for getting care, the more affordable that's going to be, because you're dealing with people who are experienced in that area, and there's not as many errors, there's not as much variability. As we decrease variability in the delivery of care, it gets cheaper and quality improves. There will be a lot of political pressure to continue to try to unravel the Affordable Care Act, but remember what I said earlier, that will happen very slowly, in my opinion, and after a lot of thought. Because after all, it ain't that bad, as my grandma used to say. Pre-existing condition coverage is a good thing. I mean, what are you going to do with insurance companies if they go back to a free market and say, we're not going to insure you because you've had cancer before. We're not going to insure you because you have high blood pressure. I'm not going to insure you because whatever the condition is. Young adult coverage is extremely important in our society. Young adults feel they're absolutely immune to any illness. They're not immune from crashing their motorcycles into brick walls, having car wrecks, and many of them come down early in life with long-term illnesses. So it's important that they remain insured and not be excluded because of prior condition. We have to look at the issue of subsidies. I get pretty frustrated myself, and part of this is personal opinion, not in my role as UTMB's representative, but I get pretty unimpressed with politicians who think that the general public should have healthcare savings accounts. I don't know whether you have ever thought about that, but most people I know have a difficulty saving up enough money just for buying a new tire on their cars or fixing a roof on their house if they have a house. 70% of the people in the United States cannot come up with $1,000 for a copayment on their insurance if they have it. They have to go mortgage something, sell something, or borrow something. And if they borrow it at a payday loan or car title loan place, the rates are so astronomical they are in debt for life. But that's our current default system right now. So having a system that's run with savings accounts is probably really good if you're the president of IBM, but not if you're an ordinary person working in the United States. Medicaid expansion is the other thing that could have really helped this process, but that didn't occur. We worry in the United States about health inequity. We worry a lot that we should close the gaps among those who have insurance and don't. Right now, there are so many social determinants out there that it's hard to know if the ACA has really addressed health inequity. And some of the new reports that have come out this year show that we've made major strides to narrow those gaps. We haven't accomplished as much as we wish we were accomplishing in the overall health inequity. Now, my theory there is health inequities take time to address. Seldom you just come in and do something and see results overnight. Don't go into a population that has obesity as a major problem and take care of that overnight. Even your AIDS education efforts take time. There's still, it's hard to believe after so many years of this particular disease that there's still people that are very ignorant. I was at a meeting, and I won't describe where, but this guy made a remark about having unprotected sex, and the other person who was a doctor in the group said, well, don't you know you could get HIV? And he says, no, man, you don't understand it. This was a girl. So, I mean, in today's time, can you be that stupid? Well, I'm here to tell you, yes, with my own ears, I heard that. So, here you go. If I told you who this person was in Galveston, you would say, oh my God, but I won't do that. We'll move on. The nation's uninsured actually has gotten lower because of this. We've insured over 11 million people, but the problem is we still have 30 million people out there who are uninsured and uncovered. And they're not getting the screening that you're interested in and I'm interested in, being an HIV test or a blood pressure or diabetes screen, prostate screen, any of those things. They're not getting prevention. So we still have a huge disease burden. we can feel good that we have covered about 25% of the people that were there of over 40 million, but we can't feel too good that there's still 30 million uncovered. I particularly like this study that was done in 2014 on the impact of the ACA on health insurance coverage for people. Most of you have probably seen it. It was published by the Kaiser Foundation. Cates and her colleagues looked at 407,000 people with HIV between 19 and 64. 87% of them had incomes below 400% of the federal poverty level. Do you know what that means? All of those individuals would have been covered on Medicaid if we'd expanded Medicaid in Texas. That's what it means. It means that that's the exact target population that we would like to reach out to. And Medicaid is the single largest source of coverage. You probably know that. Medicaid reimbursement, unfortunately, is about 60% of what Medicare is. I was looking at the average physician gets paid for HIV care less than $3,000 per year in physician fees. So it's one of those things that's really hard to motivate people to take on the care of those individuals. Most disturbing from Kate's study was that over 700,000 people with HIV are not yet in care. And that, we're going to look at why that is in just a moment. ACA and premiums, by the way, increased by 11%. The cost of getting an insurance policy didn't go down. It actually went up. These exceeded the current administration's estimates. They were really hoping they wouldn't exceed 7.5%, but 11% is pretty high. As a result of that, a lot of people canceled their ACA plans. The most popular one and probably the best is the Silver plan. Becky Grenick in our own institution highly recommended that. I went to her and just said, you know, my son needs to get some health care. He's just finished medical school. What should he get? Get the Silver plan. That gets you what you need. But you still have a pretty high deductible there. So where are we with healthcare expenditures in general? As compared to our gross domestic product? Well, we're approaching 20%, which is really high considering we're just a little over 11% in 1989. That means basically that the cost of health care, I'm not saying AIDS care here, I'm saying health care in general, has almost doubled in that period of time. That's something that is only going to get worse, not better, because we have a baby boomer generation that is consuming lots of health care now, fractured hips, repair of eyes from diabetes, amputation of limbs, rehabilitation from cardiac surgery, all sorts of things that my classmates from college are going through right now. Hopefully I can avoid those. It's a lot and it's expensive. If you read into yesterday's or today's paper, you will see that the Texas Teachers Retirement System is underfunded by $750 million. And most of us at UTMB are in TRS as our retirement plan and our health plan. So their health plan is going to take, by the time the next legislature meets, about $1 billion infusion to keep up with the current cost in health care. So leading up here, why don't we expand Medicaid? And what is the reason that we would think about expanding Medicaid? Why would we do that? Who pays, first of all? Where does most of the money come from when you expand Medicaid? Well, we do, but it comes from the federal government. So, matter of fact, over 90% of the funds would come from the federal government. Right now, the state of Texas is paying for everything when it doesn't expand Medicaid. We still provide services, but we don't take advantage of the matching funds from the federal government. Now, you said that we pay taxes. It comes from us. That's true. Well, where do your taxes go if it's not coming back to Texas? Goes to New York, Wisconsin, all those other states who did expand Medicaid. Okay, so don't ask me if I think that's foolish. I'll let you draw your conclusion. But if your federal tax dollars have been sent into Washington, one thing our former congressman was really right about here, he was libertarian. He really thought any money you paid in ought to come back to your local district. And as we say, no, we're not going to expand Medicaid, we leave that money on the table to be distributed in other places. So it would not be surprising to see a higher quality of health care and better outcomes in all those other states because they're able to do more preventive care and they're able to do a better job of treating people with chronic illness. Texas has the highest uninsured rate now in the entire nation. We would be able to put many of those people, if not all of them, into the Medicaid program, particularly at the 400% of the federal poverty level. Texas also has the poorest health outcomes in the nation. I don't know whether you have looked at the recent data. I didn't include a slide on this. I should have. For Texas, but if you took a line from Tyler, Texas to Beaumont and then drew it over to Galveston, you would see the worst health outcomes in the entire state. Not the Rio Grande Valley, by the way. And why not the Rio Grande Valley? Well, we don't have a wall there yet, and anybody who lives in the valley can go across the border and get primary care, dental care, and buy all their medications dirt cheap. Unfortunately, if you live in East Texas, the border is with Louisiana, who has nothing to offer for us. They don't even have a CVS or Walgreens on every corner like we do. So we not only have a shortage of physicians throughout East Texas, we have a huge shortage of mental health workers. Did you know that East Texas has a 60% higher suicide rate than the rest of the state? 60%. Because of a shortage of mental health workers. And I would dare say that many of your clients have a few moments of depression or get down in the dumps and could stand to go to a mental health group. Certainly we see that in diabetics who are facing chronic illness, people with COPD, heart disease, and all those. So I just ask you to think realistically where all of our patients can get the best help. Texas taxpayers are losing literally billions of dollars every year to other states that are getting that subsidization of 90%. The long-term impact to the health of Texas is going to be devastating if we continue to follow a political journey that refuses to expand Medicaid or improve our health care access. So what have other states done? I was pulling up slides. This is from 2013, and you see the dark states are those that were moving toward the Medicaid expansion. It just happened to be that just over half of the people with HIV were in states that planned to expand Medicaid, so that was good. But 4 in 10 patients with HIV were not in those states. So you're leaving 40% of your target population that you work with out of the mix here for enhancement of care. Now, fortunately, my opinion again, not that necessarily of everybody else, but the Medicaid expansion attitude changed a bit. Even in some very, very conservative states. You only see Texas, Louisiana, Mississippi, Alabama, Georgia, Florida, South Carolina, North Carolina now, and then some in the Midwest, basically saying, I'm not going to expand Medicaid. Almost everybody else has or will. We're up to 29 states, including Washington, D.C., adoption is being discussed in another 7 states, and we're down to 15 states out of 50 that are not adopting right now. So that's a major trend. Texas has pretty well dug itself in a hole that's saying no to Medicaid expansion. But you should know that the Texas Association of Business, which is one of the most powerful political lobbies in the state of Texas, representing big business and small business throughout the state, has gone on record over the last 18 months lobbying really hard for Medicaid expansion. You should also know that recent surveys show that the majority of Texans, not by just like 51%, but 60 to 70% favor Medicaid expansion regardless of political party. So it's not drawn down party lines. When we're in Austin, here's what we hear when we talk about Medicaid expansion, just so you can understand the logic. The state representatives and senators say Medicaid costs too much, it uses too much of the state budget, it's inefficient, ineffective, it's imposed on us by the feds, so we're not going to do it. That's the attitude. Now, there's another argument there that says by not expanding Medicaid, we lose federal funds, we lose human capital. In other words, people are too sick to go to work, and people die. There's an increased cost to local government because who's footing the bill if there's not Medicaid for these patients? It's your local county. It's a Harris County Health District. It is Galveston County Indigent Care. It is Dallas Health District, Bexar County Health District. All the big health districts throughout our state are overly burdened. Where do they get their money? You had the right answer. From you. If you are a taxpayer in Harris County, you're paying into a hospital district to fund this care. If there was Medicaid expansion, your hospital district taxes would either go down or go away. So it's very, very important that people understand the logic of what we're talking about here and not just pull an opinion out of the air and it not be fact-based. By the way, if there are inefficiencies and ineffectiveness, whose fault is that? Who administers the Medicaid program? It's administered here in Texas by Texans who are hired or appointed by the governor of the state of Texas. So we can't very well say the federal programs are imposed on us and they're bad. If there are changes that we want to make to those programs, nobody's stopping us from making them. And by the way, just a little annoyance to me, we spent almost $1 billion putting braces on kids' teeth in the CHIP program, kids that did not even need braces and did not meet the criteria because we did not have criteria set. Those weren't federal criteria, they were all local state criteria. So if waste and fraud and abuse are what you're looking at in the Medicaid program, it rolls up to our door here in Texas, not to the feds. We often talk about a Medicare gap, Medicaid gap in coverage, and here you see the umbrella, those people who have Medicaid, and then the marketplace subsidies of people in ACA, and you see the people who are standing out there in the rain with no coverage. That is something that has to be addressed. As long as we're hung up down there at the 100% of federal poverty level, which is between $11,000 and $12,000 a year, we're not going to do any good. With a 400% of poverty level, bumping that up to $40,000 a year, we would be able to do a lot of good. You are more familiar than I am with your HIV continuum of care. I know that, so I'm not going to speak on this, but I just wanted to remind you that as you're trying to carry that out, who do you work with to implement a holistic program like this with a good continuum of care? You have a multidisciplinary team, right? You have a medical home for that patient. I know when I was head of the TDCJ programs, I was just amazed to go down to the telemedicine clinic and watch the ease in which care can be managed by a whole team, which the nurses, I was so impressed that offenders in our system could sit down and talk about what their viral load was, what their CD4 count was, what their medicines were, and why they were on them. Education. We had Magic Johnson come out to talk to many of the offenders on location, and one of our prisoners did a great tape. And, he attributes his longevity to the fact he's never missed a dose of medicine, number one. And number two, he's always followed his doctor's instructions. And that's a powerful statement. That's what you're doing, but you can't do that without funding. I think few of you are, there's some of you who are going to do that for the passion and love of what you do, but then you've got to feed mouths at your home too and pay bills and car notes and educational loans for your kids and all that. So to affect this appropriately, we have got to have coverage for our non-elderly adults with HIV who are in care. And how that falls out in 2009 is probably no surprise to you. About 17% were uninsured. About 41% were on Medicaid. There were some other public funds. Some people were fortunate enough to have some private insurance. And some people were dual eligible and got some Medicare funds also. As we bump up and look what the ideal state would be, if we expanded Medicaid, we see that number could go up to 67% of people covered. And then marketplace subsidies would cover another 29%, leaving less than 4% for other subsidies somewhere else. Isn't that amazing? Can you see the change that would happen? And then don't forget, I mentioned to you there's 700,000 people who are currently not getting care. Superimpose them in there and see what a difference that would make, as opposed to what is happening. Well, how does the ACA help people living with AIDS? It ensures coverage for people with pre-existing conditions. That's the biggest thing. It expands Medicaid coverage in those states who were smart enough to do that. Unfortunately, we don't live in one of those. It provides more affordable private health coverage, and that's maybe kind of questionable, but if you look at it this way, many times before you couldn't get the coverage at all without paying astronomical. At least there's some regulation of that now. It lowers prescription drug costs for individuals so they can afford to go out and get the meds they need. It ensures that continuum of care. It ensures coverage of preventative services. It ensures the coverage of essential health benefits like your wellness checks and your routine screens for other things that people with health insurance get. It increases coordinated care for individuals with chronic health conditions of all types. So these are some major attributes of the Affordable Care Act. And believe me, if people come along and want to get rid of this program, those of us in the health professions have got a job ahead of us to explain to our patients what they're getting that benefits them. The one thing I haven't talked about is Orion White program. How is that affected? It continues to provide critical medical and non-medical services, as you know, including coverage for people with pre-existing and broader medical eligibility. Helps with the affordability. But basically, if people can get on ACA, Ryan White does very little right now in most states. The role is decreasing in many places because it was meant to do that. You're meant to get Affordable Care Act and not depend on this as much. Now, that's not true in Texas because Texas didn't expand Medicaid. So we are still very, very dependent on that. And we also have to keep our eye on that budget to be sure Ryan White funding doesn't go down too much and we end up with no access to care for our patients. If we want to ensure quality, those preventive services must be there. There has to be comprehensive coverage and coordinated care, your model care delivery that you use here in all your clinic sites. The expansion of community health centers in the future is going to be really important for everybody with chronic health care conditions, not just our HIV patients. We have to deliver that care in a culturally competent manner, and we have to deliver it with a well-trained workforce. Fortunately, the Affordable Care Act provided us some loans and scholarship programs for people in the National Health Corps. So that is another thing that is going to help our patients with chronic health conditions. It provided more funding for those community health centers also. So those are some things you don't hear about. Now I want to do very briefly a little vignette for you from the Texas legislature. This is real time. This occurred just less than a year ago in Austin, Texas. Representative Stuart Spitzer, the Republican from Kaufman, Texas, went to the back microphone and said, I have an amendment. I want to move $3 million from HIV funding and STD prevention programs to abstinence education. Representative Spitzer said abstinence is the best way to prevent HIV. Representative Spitzer is a doctor. Okay? Pause and think about that just for a moment. Once a budget is set, you can't add or take away money, but you can move money. So his goal was to take away money from HIV prevention programs in Texas and put it into abstinence education because he believes that that is the best way to spend the money. Well, let me show you what happened. Sylvester Turner, who is one of the longstanding members until this last year, he's now mayor of Houston, said, is it not significant that Texas has the third highest number of HIV cases in the country? And he's saying this to Representative Spitzer, Dr. Spitzer. Does it not bother you to know that there are people walking around with HIV undiagnosed? Representative Poncho Navarez and from Eagle Pass said, do you feel as a medical doctor that the position you are taking, not just from a fiscal standpoint, is prudent for the medical community? And Dr. Spitzer said, I do. I think that's the right thing to do. Harold Dutton, who is never at a loss for words, Democrat from Houston, said, were you taught abstinence education? Did it work? And Spitzer said, I've only had sex with one woman in my life, and that's my wife. And Dutton, and since you brought it up, is that the first woman you asked? And Spitzer said, I'm not sure that's an appropriate question. Back to the real world, Nicole Collier, a Democrat from Fort Worth, said, Mr. Spitzer, earlier you stated that you could not get STDs without having sex. And Spitzer said, it depends on your definition of what sex is. And then Collier says, if you still think you can't get an STD without having sex, then maybe we need to educate you. Now, ladies and gentlemen, this is real time, real life, your Texas legislature. This is the people who are elected to make these decisions. Well, Mr. Spitzer ran for re-election in the Republican primary, and he was defeated by a former legislator named Lance Goodman. So that's that. My parting slide for you is this one. Just remember, if you see a trailer on the road, the floor is probably covered with political promises. Never assume anything. Incorrect information can and does often come in the form of expert medical opinions. Political parties may choose to act upon proven facts, but rather, or not to act on them, but rather on personal preferences and prejudice, perverted to support twisted logic that appeals to voter assumptions. You're seeing every bit of that in this election. Never, never, never give up in advocating for your patients. You have a lot to do. One of the most important things you can do in not crossing the line in lobbying for a political candidate, but is educating your HIV positive patients what their rights and options are and to exercise their right to vote every time there is an election. The reason we have some of these problems is people stay home and they elect some real wackos. So, any questions? I'll attempt to ask. Thank you. That's your political forecast today. Tomorrow it'll probably have a different flavor. Thank you very much for letting me participate. Yes, ma'am. Yes. Yes. Well, we've seen these issues debated also in the forum related to women's health care in general. And when we saw the program actually ended because Planned Parenthood was the main vendor, we saw a dramatic increase in Medicaid enrollment of newborn babies. and to the tune of over $260 million because people could get contraception. Not because they were having abortions, but because there was no contraception available. So the legislature went back and they had forfeited all the federal funds and had to cough up over $100 million to put back in place a maternal program that provided contraceptions to women. And if you think about that one issue, it becomes a really important one. What if you are a young, and insert whatever nationality or ethnic group you want, lady who's in nursing school, and you have an unplanned pregnancy because you couldn't get your contraceptive, and you have to drop out of school, and you get to work at Burger King for a while. Is that fun? No. So think about those things and put them in real-term logic because it's not just about an issue of abortion. I personally am against abortion. That's my personal position and all. But I am for birth control, and I am for family planning, and I'm for people having an opportunity to finish their education on their terms. So there's some things like that you can't let your personal opinion stop somebody else. So those things occur every single day. That's one of the joys I have as coaching medical students in the legislative process. They come to the office and say, "You won't believe." And I say, "Yes, I will. They did this, and there's no evidence that supports that." And I said, "Well, you're right."
I'm just curious, that 700,000 figure that you come up with that HIV not taking, receiving care, is that within the US?
Yes, that's the United States. And that's the facts given in this paper. I don't know. Dr. Kaiser would be much more astute at that question than me. I'm assuming it was published by Kaiser, so I was assuming the numbers were
Yeah,
right.
I mean, there are different estimates on how many people, but it's that's probably on the high side, but there's still hundreds of thousands. The low side is probably 450,000, but somewhere between a third and half.
Let's even do a more practical example of taking away from a infectious disease. Most often, African American men at a young age get very few health checkups. One of their biggest problems is essential hypertension that goes undiagnosed. When those individuals, unfortunately, go to TDCJ, we frequently see young men in their 30s have to immediately go into a dialysis program because their kidneys are already shot. Why? They've never had any preventive health care. They didn't have access to getting something as simple as blood pressure. So it's not just the disease burden of HIV or diabetes. There are a lot of even, I would say, simpler things that we should be doing in screening. So those they're important programs.
Medicaid, if they have Medicaid, they could also call like somebody that has cancer too, they would be able to get on Medicaid.
Absolutely.
Because there's a lot of people that don't get treated.
And people who can't afford or access a mammogram, for instance, is a whole big difference in treating someone with stage 1 breast cancer than stage 4. I mean, the cost, disease impact to the family and to the person and all of that, just a whole world of difference. So we had to really, as healthcare providers, be an advocate for prevention and screening programs. And I really thank all of you guys who work in the education and screening prevention programs for what you do. It has a much bigger impact than I think sometimes you realize. So thank y'all. If I can be of help,
Thank you.
let me know. Thank you for letting me do that.